Welcome to another special presentation. This is a, believe it or not, puzzle. I am speaking to you, and here is my background so that we become acquainted. These presentations would not be possible without the contribution of all of the colleagues listed here and many more. Welcome to this dual story. The first point is to share with you a clinical process, and the second is to say a few main points about the observer. On the left, you see a child with a complex disorder of unknown nature, and on the right, you see the same child much improved. So it is a clinical puzzle. Perhaps you should ask your dermatologist or any other dermatologist to help you. Ask them, what do you think this is? And we may find some interesting ideas, because no diagnosis is final. All pathogenesis, etiology, and diagnosis are ideas, suppositions, and they are open to question or updates. So you see what I see, but do you really see? Can you tell what you see? Can you tell another clinician or observer? These are hyperkeratotic nodules. Nodules in different stages of evolution or involution. Some have bled, so it suggests that these are crops of different ages and therefore at different stages of biologic evolution. Notice that there are eyelashes that don't seem to be affected, nor it seems like the skin generally around the periorbit is less affected, except that's not so, because here you see the exception, and these eyelashes are gone. So look, and if you need more time, stop the motion and look. If you need to look again, stop the motion, come back and replay. So, what about the observer? This was a child seen by a junior resident in an emergency room who was a member of a residency program in a prestigious university children's hospital. It gives you an idea what was expected some 30, 40, maybe even 50 years ago, because these are historic photographs of a junior resident of pediatrics. And you could see tonsurans, meaning that there was here a haircut by whatever this agent is. You could see the child is not under distress. So what we know is that there was no itching, there was no pain, that the lesions here were limited. They were not anywhere else in the body. They were limited from here up. None of them were in the back of the neck. Interesting. So therefore, there is a preferred localization. So look again, take your time. That's all what we are going to know. And we're going to draw conclusions on the basis of this very limited information. Look how thin the epidermis appears here. Look at these ulcerations. The craving in, this is like a crater. The hair completely tonsurated or exploded, if you like. Here you have a profile of the patient, and you could see that there is virtually no lesions below this particular line. Could this be that the circulation here is richer? Well, I don't know, because the circulation in the perioral area is very, very high, and the circulation in the ear is rather limited. So, doesn't seem to be very likely. So how would you explain this localization? Well, you could say this is some agent that thrives on dead epithelial cells and therefore also on the hair, which is dead cells. But is that so in here? Probably. But then why is not so here? And as you can see, there's blanching here. So what did the observer do, a junior resident? He didn't have access to the internet. He didn't have a book on hand. This is an emergency room. He didn't have a consultant. He had his brain. And his clinical training was limited to the medical school and an internship. So he proposes hypothesis, at least to himself. He says, there is no evidence here of an immune disorder. The child has not been sick, nor it has any evidence of compromised immune system. And there are no home pits. I will add that this child came from a different climate. This emergency room is in a wet climate, but he came from a desertic climate where cacti and it's a desert, so probably the fauna and flora there are quite different. He was traveling by and came to the emergency room not just for this, but for other reasons. Then he thought, this observer, that let's see if we can formulate some hypothesis. Is hair, epidermis, two populations of dead cells limited to an area otherwise asymptomatic with no immune deficiency signs? So he said, well, let me scrape this. He found a tube in a laboratory for culture, plated it, and stuck it in his drawer, which certainly was not an incubator. Why would he do that? Well, he knew something that perhaps we need to guess later. And 1 week later, he found, wow, this was growing a big growth, just like a mold will grow on a wet wall or on bread. And his synthesis of the hypothesis here was this must perhaps be a fungal infection. So let's call it, at least temporarily, a Tinea tonsurans, capitis for the scalp, or iniencephalad, meaning neck, which is not true. We didn't see a neck lesion, and the cephalad certainly is evident here. And he prescribed what was the most safe, oldest, and proven medication. He had the culture, and he called the family to come back, and they came back, and the child was halfway to be cured. And I think the contrast is dramatic enough. So you could almost say that this was a diagnostic test, that indeed this probably is a fungus responsive to Griseofulvin. So his discharge diagnosis was Microsporum Tinea tonsurus or tonsurans. And then the subtype, maybe it was typed, maybe not. We don't have information on that. So it's time then to finish this presentation and make some points about the observer, not about the patient. Here's the patient. Now, what is about the observer? Why do we bother to tell you a little story? Because we think that the United States is a land of opportunity. we think that in the United States, immigrants contribute significantly to the society. But they can't contribute if they don't have an opportunity. And we notice a rise in nativism, racism, America First, or whatever that nationalism may be. And all of that, in our view, is detrimental to all concerned. Because this observer, had he been an immigrant to many other countries, would not have had the opportunity. So this observer is an immigrant of many lands and is grateful to many clinicians. In this particular episode, he is very grateful to a pediatrician, Helen Nash from St. Louis, who also stood as a major and well-remembered community civil rights leader. She pleaded with the university to accept the observer as a pediatric resident on a performance basis. If he didn't perform, he would agree to leave. So on a trial basis, and they accepted him. And during his residency, he made this sort of observation, but he made many others that you can find in the internet. The point, however, is that this observer considers that no clinician can earn all the credit. Every clinician that earns any credit recognizes that much of the credit belongs to clinicians who preceded and nurtured him, because medicine is a blend not only of science, but of skills, of the ability to see, the ability to synthesize, the ability to interpret, all within a framework of humanism. So this is dedicated to this famous leader of American pediatrics, and you're welcome to see what else you can find. And thank you for your attention. So, thank you again. Bonne chance, good fortune, and till soon.